The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar in the Public Health Webinar Series on Blood Disorders. This webinar is presented by the Division of Blood Disorders at the Center for Disease Control and Prevention, also known as the CDC. I'm Dr. Michael Strife, and I serve as Medical Director of the Johns Hopkins Anticoagulation Management Service, and I also chair the Medical and Scientific Advisory Board of the National Blood Clot Alliance, as well as the National Comprehensive Cancer Network's Venous Thromboembolism Guideline Committee. I'm delighted to be with you today to moderate today's webinar on venous thromboembolism in children. Before I introduce our guest presenter, I'd like to go over a few points and helpful tips for joining the webinar. Upon joining the webinar, you will see there are two audio options. You could opt to listen via the speakers on your computer, or you can call in and use your phone. If you use the phone option, the webinar toolbar will provide you with the phone number and the access number, as well as the audio PIN number to use. All audio will be muted. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of your toolbar. The presenters will respond to as many questions as time allows. Today's webinar will last approximately 1 hour. Please note that this webinar will be recorded. We will begin today's webinar first with two brief audience polls. First, we're interested in knowing more about you. Please select your response to the poll question now. So it looks like we have a large number of healthcare providers, as well as public health professionals, some persons with thrombophilia or family members, some community-based organizations, and industry partners as well. Interesting spread, different parties. Now we're going to do a second question to find out where you're calling in from. So it looks like we have a large number of attendees from North America, but also have attendees from South America, Western Europe, and Asia, so almost all over the world. It's great to have such a broad group with so many different experiences. So now it's my pleasure to introduce today's presenter, Dr. Neil Goldenberg. Dr. Goldenberg is a professor of pediatrics and medicine in the Division of Hematology and the Director of Research at Johns Hopkins All Children's Hospital in Florida. He's also the Chief Research Officer of the Johns Hopkins All Children's Research Institute. Dr. Goldenberg also directs the Johns Hopkins Medicine Pediatric Thrombosis Program, as well as the Johns Hopkins All Children's Pediatric Stroke Program in Florida. He is the global principal investigator for the NIH-sponsored randomized trial entitled Prospective Multicenter Evaluation of the Duration of Therapy for Thrombosis in Children, also known as KIDS-DOT, a trial that involves more than 50 participating centers worldwide. In addition to his work as a PI, Neil is also a steering committee chair or data safety and monitoring chair for several NIH and industry-sponsored multi-center trials. Dr. Goldenberg has co-authored numerous international clinical and clinical research guidelines for pediatric VTE. And with that, I'd like to introduce Dr. Goldenberg and hear his presentation. Thanks so much for joining us, Neil.
Thank you, Dr. Strife, for the introduction, and it's a pleasure to speak on venous thromboembolism in children for this 2019 scientific update. By way of outline, today we're going to review the incidence and impact of VTE in children, discuss the etiology and risk factors, review presentation, diagnosis, and classification of VTE in children, and then we'll move toward an overview of antithrombotic therapy approaches, as well as a summary of the American Society of Hematology guidelines for treatment of venous thromboembolism in children. We'll then discuss the acute and long-term outcomes of VTE in children, as well as what is known regarding prognostic factors and predictors of outcome, then wrapping up with key unanswered questions in the field that are being addressed in current clinical and translational research, leaving hopefully plenty of time for question and answer. By way of disclosure, I participate, as Dr. Streif mentioned, in steering committees and data and safety monitoring committees for pharmaceutical industry-sponsored trials, and also provide engagement in thought leadership and design and oversight of antithrombotic trials through a academic research organization and the Atlas Group. Research support is received from the National Institutes of Health, NHLBI, for the KIDS trial that Dr. Streif referred to earlier. I also need to disclose that this presentation will contain some discussion of off-label use of anticoagulants, and unfortunately in the routine clinical care of children with VTE, we are using anticoagulants that do not have a formal FDA indication for VTE treatment, although in some cases there has been progress with dosing information in the pediatric age group. So I'll move into the introduction and frame some context for VTE in children by describing what's known about incidence and giving a sense of the disease burden in terms of impact. Some data from 2014 from Stein and colleagues had shown that there is a bimodal peak in incidence of VTE in children affecting infancy, particularly the neonatal period, as well as adolescent age groups. And you see that overall the rate of diagnosis is approximately 5 per 100,000 children per year. And that overall epidemiologic data suggests a fairly infrequent disease, although as you'll see throughout this talk, in hospitalized children, the incidence of VTE is quite high. The incidence of pediatric VTE and or its diagnosis does appear to be increasing markedly, and in fact, colleague Leslie Raffini and colleagues in Children's Hospital of Philadelphia had evaluated national data from the FIS database, showing that there had been a 70% increase over a 7-year period from 2001 through 2007 in the incidence of VTE in children, and that this rise in incidence was a common theme across all age groups in the pediatric range. Now, with regard to impact and healthcare burden, the incidence rate and U.S. Census data combined would suggest that over 9,000 children will be diagnosed with VTE in the U.S. in 2019. And given some data from Sarah O'Brien and colleagues that the average cost of care for children with VTE is approximately $8,000 per child, the overall cost of VTE treatment this year in the U.S. should be anticipated to exceed $71 million. And that, however, is likely an underestimate, given that the key driver of cost is anticoagulant therapy, and that's likely to become more expensive over time as there's increased utilization of the novel oral anticoagulants should they show appropriate efficacy and safety data. And I'll mention later some of the ongoing studies and some of the few published studies to date. In addition, the overall burden and cost of care need to consider the lifelong consequences of VTE, and we'll discuss briefly chronic venous insufficiency, or what is known as the post-thrombotic syndrome following deep vein thrombosis, which is a problem as much in children as it is in adults, and the costs associated with post-thrombotic syndrome are difficult to measure. So we'll now move to a discussion of the etiology and risk factors of VTE in children. And as in all age groups, it's very helpful to think of the triad of Virchow consisting of venous stasis and hypercoagulable state, as well as endothelial damage. So I'll briefly go through some examples of each component of this triad. Venous stasis, or slow or reduced blood flow, can exist in the setting of a reduced mobility postoperatively or for other reasons of hospitalization, casting and splinting with extrinsic compression on a vessel, and again, a sedentary or reduced mobility state. Also, certain syndromes like leukostasis syndrome in acute myelogenous leukemia and dehydration are also thought to cause venous stasis. With regard to endothelial damage, unfortunately, it's necessary to use central venous catheters for resuscitation in children and delivery of certain medications, particularly chemotherapy, and in some cases for venous access purposes for requirements of blood draw and monitoring when peripheral access is not suitable or lasting. That central venous catheterization, as we'll see later, is a very common underlying factor in children diagnosed with VTE, and it's thought to cause endothelial damage as well as affect blood flow through the vessel. Sepsis, trauma, the presence of anti-phospholipid antibodies, as well as the administration of chemotherapy, are all examples of endothelial damage prone states. And then the hypercoagulable state we'll talk about a bit more in this talk, but there is both inherited thrombophilia or hypercoagulability, as well as acquired hypercoagulability or thrombophilia. And acquired thrombophilia is quite prevalent in ill children. Inherited thrombophilia in a severe state is uncommon, but in mild states, as we'll see, is much more common in children and adults. With regard to comorbidities, commonly found putative risk factors for VTE in children, the presence of a central venous catheter, both in the cohort description by Paul Monagle and colleagues based on Canadian registry data, as well as multiple subsequent cohorts and registries have really identified central venous catheter as the most or one of the most common underlying factors. Depending on the individual patient population that's being studied, congenital cardiac disease and cancer are also common underlying diseases. Infection is also quite prevalent in many cohorts. In order to demonstrate a true association as far as risk, the question really becomes the frequency in patients with VTE compared to the frequency of those underlying risk factors in patients without VTE. So not all of these factors shown in terms of prevalence bear out in terms of increased odds of VTE. We do know from recent meta-analysis findings from Arash Mahadran and colleagues based on several studies performed to date, usually at individual centers, that in hospitalized children there are some common themes around risk factors when one looks at the frequency among patients who develop VTE compared to those who have not developed VTE. And that includes critical illness, particularly the use of mechanical ventilation, having a major infection or state of systemic inflammation, central venous catheterization, as we mentioned earlier, and an increasing length of stay in the hospital, all suggested as risk factors for the development of VTE in the hospitalized child. With regard to hypercoagulability or thrombophilia states, the presence of an inherited anticoagulant deficiency has been shown to markedly increase the risk of VTE. While these anticoagulant deficiencies appear to be rare in older adults presenting with a first VTE, when one looks at VTE that is onset in young patients, these become more frequently identified, as one might expect for young onset VTE. And we're talking about protein C deficiency, protein S deficiency, and antithrombin deficiency in particular. It's been seen from work by Guy Young and colleagues in a meta-analysis of observational studies that those children with VTE who have inherited anticoagulant deficiencies, or pardon me, those children with inherited anticoagulant deficiencies have an increased risk for recurrent VTE when they have had a first VTE. So the risk of an incident VTE is thought to be increased, but also it's been demonstrated that among those who have already suffered VTE, the risk of having a second or additional episode is increased with these anticoagulant deficiencies. In terms of population-based risk estimates, the factor II mutation or prothrombin mutation, as well as the factor V Leiden mutation, are commonly discussed and frequently tested in families where multiple members have been affected with VTE, especially at a young age and or in an unprovoked VTE scenario. So it's helpful to understand a little bit about the prevalence and the magnitude of risk. Factor II G2021A mutation, heterozygous variant, is present in 1 to 2% of Caucasian populations and confers about a twofold increased risk of VTE. The factor V Leiden variant in heterozygous state is found in about 5% of Caucasian populations and confers about a 5-fold increased risk of VTE. The presence of the oral contraceptive pill, historically, this exogenous estrogen, has been associated with a 4-fold increased risk of VTE at a population level. However, the effect of the oral contraceptive pill is synergistic with factor V Leiden, both impacting the activated protein C resistance pathway, a natural anticoagulant pathway. And for that reason, we see a 35-fold increased risk when those two risk factors are combined. Certainly a homozygous state of the factor V Leiden variant is a very potent risk factor for VTE, conferring an 80-fold increased risk. I mentioned acquired thrombophilia as being highly prevalent in ill children, this is commonly found in states of infection, systemic inflammation. We see elevated levels of factor VIII, of von Willebrand factor. We see the presence of antiphospholipid antibodies in sepsis and in some post-viral states, and as mentioned earlier, the oral contraceptive pill with exogenous estrogen confers a state of activated protein C resistance. In addition, we can see acquired antithrombin deficiency, and I mentioned that antithrombin and protein C, those anticoagulants can confer a potent prothrombotic state when deficient. Acquired antithrombin deficiency is seen in nephrotic syndrome. It's seen in L-asparaginase administration for acute lymphoblastic leukemia and in other syndromes. The antiphospholipid antibody production that I mentioned earlier can be seen in a variety of viral and bacterial states. Influenza and varicella chickenpox systemic infection is one in which antiphospholipid antibodies can cause a potent hypercoagulable state and has been associated with stroke historically. There's a lot of interest, as there should be, in obesity in 2019 with the marked rise in obesity, particularly in our youth. And the question arises as to whether that's an independent risk factor for young onset venous thromboembolism. Few studies have been performed to date, although I'll highlight 3 of them here. Halverson and colleagues published in 2016 a case control study of children based at a single institution in North Carolina in which BMI Z-score was independently associated with incident VTE, so that for each increase in Z-score by 1, there was a threefold increase in the odds of VTE. This was consistent with separate findings by Stokes and colleagues from University of Kentucky, a case control study in children who were matched on age and gender, and found that the odds of incidence VTE are doubled in obese children. Most recently, Proska and colleagues within the last year reported a retrospective cohort of children with acute lymphoblastic leukemia based at Children's Hospital of Los Angeles from 2008 to 2016, and found a rate of 9% for symptomatic venous thromboembolism, 70% of which occurred during the induction phase of chemotherapy. In obese ALL patients, however, the rate of symptomatic VTE was nearly 20%, and obesity in that population was independently associated with incident symptomatic VTE. The odds were tripled or even higher among obese children. So now we'll move into the presentation and diagnosis as well as classification of VTE in children, which creates a bit of a common language by which we can then discuss overall concepts on antithrombotic therapy as well as the recent ASH guidelines. Lower extremity DVT of the legs can present within a number of different segments of the vasculature and sometimes can be proximal approaching the inferior vena cava, presents with painful swelling of the leg, sometimes as abdominal or pelvic pain, and therefore can be a difficult diagnostic issue. Typically, compression ultrasound with Doppler is the diagnostic modality, although when the clot is presenting or extending into the abdomen, often additional imaging with a CT venogram or MR venogram is necessary. With upper extremity DVT, this presents with painful swelling of the arm when it's symptomatic, and a compression ultrasound with Doppler is helpful, particularly distally in the arm, but as the clot extends more behind the chest wall, a CT venogram or MR venogram is necessary in order to have the appropriate diagnostic performance to be able to reveal the DVT. Pulmonary embolism can present in various segments of the pulmonary arterial tree, and when it's close to the lining of the lung, it often presents with chest pain on deep breathing, but in general, independent of location, will typically present with shortness of breath, sometimes with low oxygen levels, and occasionally with coughing up blood. Here, the index of suspicion has to be high when there's a patient who has some of the risk factors that we've talked about before: immobility, oral contraceptive pill, family history of VTE at a young age. And spiral CT angiography is one of the modalities of choice. Unfortunately, some children have had particularly previous episodes of PE and are chronically at risk, and therefore may undergo multiple spiral CT angiography procedures in an effort to spare radiation. In some scenarios with a stable patient, it can be appropriate to do VQ scan when there's experience at the pediatric institution in doing so. Cerebral sinovenous thrombosis is a very common subtype of venous thromboembolism in children, more common proportionally than among adult VTE, and can present much like the other VTE anatomic distributions we've discussed at various segments of the vasculature and the cerebral sinovenous system, and typically will present with headache, often more severe than usual or more protracted than usual. There can be associated nausea or vomiting, can be positional in nature when there's increased intracranial pressure. Blurred vision and other neuropathies can occur. And the diagnostic modality is typically an MRV of the brain or a CT venogram of the brain. It's important because many children, the predisposing factor is head and neck infection, particularly a complicated ear infection, to evaluate for mastoiditis on the imaging, and also in these children to have neuro-ophthalmological examination to evaluate for any optic nerve swelling from increased intracranial pressure. Other sites can be involved in children. We have renal vein thrombosis, hepatic vein thrombosis, portal vein thrombosis, and I won't go into detail at this time on those VTE subtypes. But we do talk about symptomatic versus asymptomatic VTE, and as I'll mention shortly, that can present a treatment conundrum as far as the guidelines and the evidence to date can reflect. Also, provoked versus unprovoked VTE is an important classification upon which some of our evidence is based from the adult trials that have been performed. The most common subtype in children is provoked VTE. Greater than 90% are provoked, and by provoked we mean that there is a clear clinical risk factor identified, whether that's a recent hospitalization, central venous catheterization, or some of the other examples that I list here. So how do we treat VTE in children? Conventionally, we use anticoagulants like heparins and warfarin, and the original data supporting the use of anticoagulants for VTE comes from adult trials in the 1960s, showing that the risk of pulmonary embolism or of extension of deep vein thrombosis in the leg is reduced with anticoagulation compared to placebo. And so the more recent approvals for anticoagulants, including the direct oral anticoagulants, have looked at comparative efficacy and safety relative to warfarin or to low molecular weight heparin, et cetera. The initial acute treatment in children is typically with low molecular weight heparin or unfractionated heparin, particularly in patients who may be unstable or have a high bleeding risk. Often parenteral therapy, unfractionated heparin, for example, will be used. And in the subacute therapy beyond the first week, one of the most common agents is low molecular weight heparin, and in some subgroups of children, warfarin is used to complete what is typically a 3-month course for a provoked VTE, and we'll talk about the duration of therapy shortly. Warfarin can be challenging, especially in children, and prior research from Leslie Mitchell and colleagues has shown that age, as well as enzymatic activity, diet, concomitant medications, and of course adherence are important determinants of the INR, which is our measure of the level of anti-clotting effect in the blood of warfarin therapy. But in children, age appears to be the key determinant of that variability in the therapeutic dose per kilo to achieve the goal level of INR. There are alternative anticoagulants used in children, such as the 10A inhibitors and thrombin inhibitors, and those can be given orally with a few options or subcutaneous or intravenously. As I mentioned earlier, we don't have an indication in children for VTE treatment for these agents, so I list them here knowing that these are all used off-label, although in some cases with some pediatric dosing information provided in the adult labeling. Some studies have been done recently and published recently in the use of the direct oral anticoagulants. The dabigatran trials in various age groups have looked at PK and PD, pharmacokinetics and pharmacodynamics and safety in relatively small studies published in 2016, 2017 that really provide the only data in children published on these dose finding and safety perspectives. With rivaroxaban, there's a phase 2 study that is reported on clinicaltrials.gov and not yet published, involving 99 patients in a PK, PD, and safety multi-dose setting across various age groups. We also need to talk about thrombolytic therapy because in certain scenarios, clinicians may choose to lyse a thrombus rather than to quote unquote thin the blood or provide anti-clotting therapy. And in this case, the goal is to reestablish blood flow rapidly. I'll mention the ASH guidelines relative to this, but this TPA, tissue plasminogen activator, for example, can be administered through a catheter-directed approach or systemically. The ASH guidelines recently published contain 30 recommendations overall. Several are applicable to all VTE, and there's some scenario-specific recommendations as well. There's an overall preference expressed for management that's guided by a pediatric hematologist, and there is mention that the future holds separate guidelines for dosing and dose monitoring, for diagnostic evaluation, and for prevention of VTE in children as specific areas that will be dealt with in more depth. I wanted to summarize the main recommendations, which include a preference for anticoagulation versus no anticoagulation for symptomatic DVT and PE, and a strong recommendation for that. And the choice of either anticoagulating or not anticoagulating for those DVT or PE that are asymptomatic. Cerebral sinovenous thrombosis is strongly recommended for anticoagulation when there is no associated intracerebral hemorrhage, and when there is intracerebral hemorrhage, a conditional recommendation to anticoagulate. For right atrial thrombosis, there's also a conditional recommendation to anticoagulate. The duration of anticoagulation is recommended at less than or equal to 3 months for provoked VTE, which also is concordant with the adult guidelines for treatment when the main provoking risk factor is non-chronic. Additional recommendations in specific scenarios include the use of thrombolysis in hemodynamically unstable pulmonary embolism patients, but preference against thrombolysis in other scenarios. The use of an IVC filter in children and pure vena cava filter is also recommended to be quite selective and reserved for patients who have an absolute contraindication to therapeutic anticoagulation, or those who have failed anticoagulation in a setting that is high risk for pulmonary embolism or for poor capacity to tolerate a pulmonary embolus. And in that case, the recommendation is to use a retrievable rather than a permanent filter, and to remove that filter as soon as the contraindication or the high risk for PE has subsided. The question also comes up quite often in clinical care around whether a central venous catheter should be removed, and if so, when. And there's a strong recommendation that if a catheter is not needed for many reasons, including for VTE treatment purposes, that catheter should be removed. However, when that catheter is needed, if there has been a therapeutic failure of anticoagulation, for example, progression and extension of the thrombus or pulmonary embolism, that if there is alternative access available, that central venous catheter at the site of thrombus should be removed. There are many therapeutic challenges, however, and unfortunately the guidelines cannot provide recommendations on all scenarios. So a number of colleagues and I have gotten together to put on a national U.S. Pediatric Thrombosis and Stroke virtual case conference, which has been very helpful to provide input and shared experiences around management of difficult cases of pediatric VTE on a monthly basis, and has been also a venue by which trainees can gain more experience and access to experts around the country and hopefully beyond over time. And I think that kind of effort is going to be necessary in areas where evidence still remains, in some cases, less robust than we would like for management guidance. And before wrapping up, I want to talk about the long-term outcomes of VTE as well as what we know about prognostic factors and some current unanswered questions. So recurrent VTE, development of post-thrombotic syndrome, and development of clinically significant bleeding are important acute outcomes and long-term outcomes in the case of recurrent VTE risk and PTS risk. And in children, some data have suggested that the risk is around 10% for recurrent VTE at 2 years, that the risk of post-thrombotic syndrome is a little more than 1 out of 4 patients, much like in adults, and that the risk of major bleeding in overall VTE treatment populations in children is around 2% for a course that's limited to 3 or as much as 6 months. And the risk of mortality is around 2% in most studies that evaluated mortality in children, but in the vast majority of those cases, the mortality is related to the underlying disease rather than necessarily to the VTE itself. Post-thrombotic syndrome I mentioned, and we'll just take a second to indicate that this is a syndrome of chronic venous insufficiency following DVT that has gained more attention in the last decade than previously, and it's the recognition that there is often intermittent swelling or can be chronic daily swelling of an involved extremity, irrespective of whether there is residual clot, if there's been venous valvular damage, and this can manifest with stasis dermatitis with superficial collateral venous circulation being visibly dilated. And in the worst cases, ulceration, and unfortunately can cause impairment in quality of life due to symptoms of pain, aching, heaviness, tightness, and impairing the ability to be active. And the risk of PTS in children, as I mentioned, is under active study, but appears to be similar to that in adults. Prognostic factors for recurrent VTE and for post-thrombotic syndrome are still very much the subject of active investigation, but some earlier work had shown that elevated levels of factor VIII and D dimer appear to portend an adverse outcome of thrombosis in children when one forms a composite outcome of recurrent VTE, the development of PTS, and the persistence of VTE. More specifically around the risk of recurrent VTE, a German study from 2001 from Ulrike Novak-Gödel and colleagues had shown that among children with unprovoked VTE, the odds of recurrent VTE may be quite increased among those who have 2 or more inherited thrombophilia traits. So some key unanswered questions involve the duration of anticoagulation, and I'm involved with an ongoing multi-center trial where we hope to address the question of 6 weeks versus 3 months for provoked VTE anticoagulant duration in children up through age 21. And this considers the risk of bleeding on anticoagulation versus the risk of recurrent venous thromboembolism, either while on or off anticoagulation. There are also important unanswered questions around the safety and efficacy and the reversal of the newer direct oral anticoagulant agents in children. And as I mentioned, there are ongoing studies and a few early published studies, particularly an ongoing study with regard to reversal of these agents in children is going to be very important to continue. And questions remain about the safest way to prevent VTE in hospitalized children where the incidence appears to be highest. Number of single center studies have led to information, as I mentioned earlier, around risk factors, but prospective validation of identifying the highest risk groups and then doing clinical trials to assess the safety and efficacy of anticoagulation in that targeted group are an important future outlook for the field. So I thank everyone for their interest in this topic and Dr. Strife for moderating, and we'll open for questions.
Thanks, Neil. That was a wonderful, comprehensive review of all that's going on, kind of the waterfront in everything on the waterfront in pediatric VTE. So there's a number of questions rolling in, so we'll get to the questions now. One listener was interested in MTHFR mutations. Is this still considered a risk factor in children? What should they do with this information?
So that's an excellent question around MTHFR, and I'm glad it was asked because I didn't spend time on that issue. We know that hyperhomocystinemia is a risk factor for thrombosis in children and in adults, and it's thought that the clinical relevance of the MTHFR variants, which are quite common in the population, that those variants act through hyperhomocystinemia, high homocysteine levels. Data from Europe has suggested that those are independent risk factors for thrombosis in young adults and children and older adults. In the U.S., the data are less conclusive, and some studies have suggested that there is no increased risk associated with MTHFR variants in terms of VTE onset in children. In terms of practice, I still measure homocysteine levels, but I don't routinely measure MTHFR in families with history of thrombosis, nor in children who are recently diagnosed with thrombosis.
Very good, very good. Very similar to what we do in adults. There's a number of questions that are asking about prophylaxis. One was prophylaxis in the ICU setting. The other was, what is the recommended prophylaxis for hospitalized patients? Could you give any information regarding that? Because I know you've been working on that area.
So here is where I think it's exciting to see that there's a lot of interest in research and an approach to take really a risk stratified paradigm to identify first which children are at greatest risk, and then to do a diligent approach at studying the safety and efficacy of anticoagulation in that population. But we're still very early in that overall pathway. So at this time, it's really not possible to use evidence to inform a recommendation on which subpopulations of children in the hospital should receive prophylaxis and what type of prophylaxis should they receive, mechanical prophylaxis versus pharmacologic prophylaxis. At the same time, we have in front of us a real problem in terms of preventable pulmonary embolism, preventable deep vein thrombosis as an unfortunate complication of care in hospitalized children. So I think it's very appropriate that many centers have used a consensus-based approach to try to identify the highest risk groups, and on a case-by-case basis, at least have VTE prevention as part of the clinical assessment and treatment plan of those patients. So it's tough to generalize, but I think those who are perceived based on their clinical picture as having low risk for bleeding, but who have multiple risk factors that have been shown from prior studies that are largely single institutional in terms of mechanical ventilation or prolonged length of stay, presence of a central venous catheter, significant infection, particularly with signs of systemic inflammation. When children have, multiple risk factors, perhaps 3 or more, many centers are considering anticoagulation in that scenario when the bleeding risk is low, and reassessing frequently as to whether anticoagulation should then be stopped as the child becomes less ill or develops higher bleeding risk. I think many children will fit a more moderately risk category, and in those circumstances, the safety would appear to be good for using sequential pneumatic compression devices as opposed to anticoagulation. And I think the challenge just being the lack of evidence basis for that. And so I think it's important work to be done locally at each center until we have the larger evidence basis.
And any drug doses recommendations at all? I mean, that's another question, that if there are certain drugs you use for prophylaxis and drug doses, or is it still too early to kind of make recommendations in that regard?
So I think over the next few years, we'll start to see some reports around the description of institutional experiences where different regimens have been used in children and what the bleeding risks are. There have already been a few reports. Many centers are using a once daily low molecular weight heparin approach. Other centers are using low dose twice daily approach with the sense of avoiding a therapeutic level of anticoagulation at any period in a 24-hour cycle, although less convenient and less benign in terms of giving twice daily injection. Sure. And so I think here again, it's important to know that there are not strong data to inform when having these discussions with families and patients, what are the risks of bleeding, what are the risks of VTE in making those decisions. But some common dosing regimens include the ones I just mentioned with the low molecular weight heparins.
Terrific. And there was also someone who was wondering about the peri-procedural period. Are there recommendations for peri-procedural management of anticoagulation in children that are on warfarin, for instance, and need a invasive procedure?
So that's also an excellent and very pragmatic question. I think the use of warfarin for VTE management is not as common as it used to be when we have guidelines around time-limited therapy, 3 months or less. But there are other patient populations for which longer therapy is appropriate. And as I mentioned, there are the underlying severe thrombophilia states. There are those with unprovoked VTE or those with provoked VTE who have chronic risk factors. So it's important to have an approach. There are 1 or 2 published studies that describe very small cohorts of patients in whom warfarin was stopped generally 1 week prior to an invasive procedure, where low molecular weight heparin was then instituted the next day and up through approximately 24 hours prior to procedure. And then collaboratively with the surgeon or other individual performing an interventional procedure, a decision is made about how soon postoperatively, based on patient factors, surgical factors, evidence of good control of hemostasis, what time period, is it 24 hours post-procedure or what have you, that low molecular weight heparin and warfarin could then be resumed with the plan to transition off of low molecular weight heparin once warfarin is again at the targeted INR.
Terrific. There's also a question about central venous catheters. If you have a central venous catheter-associated venous thrombosis, must you take the catheter out immediately, or how is your approach to those events?
Again, a really pragmatic and important question, really common scenario. And here we have, I think, the benefit of the ASH guidelines having addressed this important pragmatic concern, recognizing that there's not strong evidence to support recommendations, but nevertheless, as was briefly reviewed, the recommendation that if a catheter is not needed, or if the VTE, the DVT has progressed, to consider for sure removing the central venous catheter. And in that scenario, ideally one would have treated for at least a few days at therapeutic doses, according to those guidelines, in order to best attempt to assure a low risk of embolization when removing the catheter. Those are the consensus-based guidelines, not a lot of data to support them, but that's also the practice that I myself have used and a number of colleagues have used.
Terrific. And what about your approach to the evaluation for thrombophilic states? What's your recommendation of when to do that? And who do you evaluate for thrombophilia? I would expect that in children there are probably more thrombophilic states present than in adults, in the adult population.
Excellent question, a very hotly debated issue and a very healthy debate because I think the values and preferences of the patient and family are important to consider. When one looks at the overall cost effectiveness of thrombophilia testing, it's very hard to justify thrombophilia testing even among those who present with VTE at a young age. However, when speaking with patients and families, they feel very often, in my experience, that there's a lot of strength in the knowledge of whether that child has chronic risk factors for future VTE, and in particular, given that there's evidence basis for an increased risk of recurrent VTE, among patients with protein C, protein S, or antithrombin deficiency. My preference and typical recommendation has been to at least measure those three anticoagulants in patients who have had VTE at a young age. However, our goal is also to prevent the first catastrophic VTE in a young patient. And so when there's a strong family history, particularly at a young age, or of unprovoked VTE, I think it's very appropriate to evaluate for those that have a highest risk for incident VTE. And again, the anticoagulant deficiencies that I mentioned are important. An argument is often also made that if one has a homozygous state for prothrombin mutation or factor V Leiden mutation, that would confer a significant risk of VTE. So that's also a consideration, although those tests can be quite more expensive than the anticoagulant deficiencies. So a little bit about my practice, but I think it's important just to recognize that there is a wide variability in thrombophilia testing and very difficult to show the cost effectiveness. So I think that patient and family conversation about how the test results would inform the management plan are very helpful until we have more evidence basis for how that does guide management.
Terrific. There's a question about thrombolysis in DVT that they're referring to the ATTRACT trial, that was I believe just in adults, but what is the practice in children as far as use of thrombolysis when treating deep venous thrombosis?
Yeah, so there was a very nice survey done and published around 2008, 2009 regarding hematologists and other practitioners practice around use of thrombolysis in pediatric DVT. And the ATTRACT trial findings probably impact those findings that preceded ATTRACT. My experience, and also in speaking with a lot of colleagues, is that those patients who present with an occlusive, extensive iliofemoral DVT, particularly if they've had a previous DVT in that venous location, are offered catheter-directed thrombolysis when it's technically feasible to do so. We know from evidence from Susan Kahn and others in adult populations that places patients at a high risk for post-thrombotic syndrome, and so the thought is to restore blood flow as early as possible. The evidence for that is lacking. There's also scenarios like Paget-Schroeder syndrome or May-Thurner anomaly, where when it's highly suspected, using a catheter approach to lyse the clot and make a definitive diagnosis is thought as an appropriate way of reducing a future risk in a thrombosis-prone state. However, I think the ATTRACT trial is important to consider that in that study, the outcome of post-thrombotic syndrome was not limited to clinically significant post-thrombotic syndrome as its primary analytic endpoint, and also didn't limit the patient population to some of the more severe presentations with, iliac involvement, iliofemoral occlusive DVT. And so I think there's still significant question about whether a trial that were designed that way in a young population might actually show long-term benefit. So I think there's practice variation, and I think with the appropriate technical expertise, there are some published cohorts to suggest that the approach can be used safely and effectively, knowing that those weren't comparative trials yet.
Terrific. And there was also, I guess, someone that wanted more detail on your approach to managing someone that has cerebral venous sinus thrombosis with hemorrhage. If you decide to treat with anticoagulation, do you stop if there's worsening of hemorrhage? What's your practice in that complex patient?
Yeah, and that's unfortunately common because about 20% of VTE in kids are cerebral sinovenous, and about 20% of those will have some evidence of intracerebral hemorrhage at presentation. I personally in my practice support the ASH guideline approach of strongly considering anticoagulation in patients with CSVT who have evidence of intracerebral hemorrhage. But I think, again, it's an important conversation to have with the family and the patient, and when possible, and that I often will select a relatively lower prophylactic dosing approach and do repeat imaging, and if that appears to be well tolerated with no radiologic evidence of worsening bleeding, then we'll work toward a therapeutic approach, at least in many scenarios, particularly of ill children, and in others starting out with traditional therapeutic approach. But again, monitoring with follow-up imaging, I think, has been helpful.
Terrific. There's also, you spoke a lot about children as a group. One of the attendees is wondering if you had, what was your approach to the very young neonates that are less than 28 days to when they develop a deep venous thrombosis or pulmonary embolism? Does it differ?
It's another excellent question, and because, as I mentioned, the bimodal peaks in incidence include neonates, this is a common scenario that we need to wrestle with. And so one thing that's important to recognize is that the dose per kilo required to achieve a targeted level of anticoagulation with low molecular weight heparin is that dose per kilo requirement is higher in the younger child than in the older child, and in the earlier stages of infancy than in later infancy, based on several studies to date with different low molecular weight heparin. So being aware of the appropriate dose, starting dose, and in pediatrics there's a preference for monitoring, although we can't really show a relationship between monitoring level and clinical outcomes. That has been the convention at most centers. And so I think being cognizant of the appropriate dose at age is important. However, as a child is more and more premature, the risk of intracerebral hemorrhage is obviously a concern. And so one is often faced with dosing lower than will achieve a therapeutic level, but assuring on serial imaging that there aren't hemorrhagic complications before gradually getting toward a quote-unquote therapeutic dosing. I do tend to treat, after talking with families, that the goal is to reduce the risk of clot progression, and that even if a clot is small or a child is, quote unquote, only an infant, that it is as important to me to reduce the risk of thrombosis when that's the value and preference of the family, then I tend to treat in those infants rather than withhold therapy.
Is there any role for aspirin in older children? It's been used in adults for VT, like prevention or recurrence. Is there any literature that would support that in the pediatric patient?
The question comes up often, and I think as Mike, as you often address in the adult population, the informed patient is aware that some studies and some recommendations would suggest the use of aspirin for long-term secondary prevention. In kids, I still recommend that if there is secondary prevention, that it's anticoagulation. For venous thrombotic events and arterial thrombotic events, it's a different story, where express a preference for antiplatelet therapy. I think we're starting to understand that there's a little more overlap between the two in terms of the rationale of kind of crosstalk between platelet-based factors and more of the fibrin-based factors involved in thinking of arterial and venous clots. So I, in my practice, do not use aspirin for the treatment of VTE in children, nor for secondary prophylaxis in VTE, although in stroke and arterial thromboembolism, that's the mainstay. I think, there's certainly a strong question to be made about whether in, for example, orthopedic surgery, primary prophylaxis of VTE in children, whether antiplatelet therapy may have a role. And I think that the data are largely from adults.
Well, Neil, this has just been a terrific hour, a terrific presentation. I mean, there's just more and more questions rolling in. I mean, it's a tribute, I think, to your presentation and the interest in the data in this area that we've got so many questions on. I apologize we haven't been able to get to all of them, but I would like to thank Dr. Goldenberg for a terrific webinar today. I'd also like to thank each of you for joining us, and we'd like to thank our colleagues at the National Blood Clot Alliance for hosting today's webinar. Very shortly, you will receive an email asking for your feedback, so please respond with your comments. If you have any additional questions about today's presentation, please contact Cynthia Sayers at csayers@cdc.gov. This webinar will be archived and the content will soon be available at the CDC's Division of Blood Disorders website as shown on the slide. Thank you very much for joining us today and have a great afternoon.